morning. I hope that you are all doing well. Thank you very much for joining us at this early morning session. I'm going to present you a stroke case which was supposed to be cryptogenic at the beginning of our investigation. The case was prepared together with my younger colleague, Dr. Tamara Švabić. My name is Milija Mijailović, and we are both coming from the neurology clinic of the Clinical Center of Serbia in Belgrade. Our patient reported that one day in September 2019, during daily walk, he suddenly experienced dark curtain which appeared over patient's left eye. It lasted for about 10 minutes, and afterwards the dark curtain disappeared spontaneously and completely. Who is our patient? He is a 75 years old man. He is a passionate smoker. He is having arterial hypertension and 1 year history of paroxysmal atrial fibrillation, which was properly treated with warfarin. 3 days later, after the initial symptoms, he is having acute onset of speech impairment. It started at about 11:20 a.m. and he appeared at our emergency department about 3 hours afterwards at 2 p.m. In his neurological examination, we found sensory motor dominant motor dysphagia with the right central facial palsy. His NH stroke scale score was 4. He had elevated blood pressure, 160 over 100 millimeters of mercury. His glycemia level was 5.1 millimoles per liter. He had sinus rhythm on electrocardiography. His INR was in therapeutical range, 2.2. He had increased level of LDL cholesterol, 4.6. On his plain CT, we found no signs of early ischemia, no ischemic or hemorrhagic lesions. There are signs of mild cerebral small vessel disease expressed by leukoariosis. At that moment, we decided not to treat patient with acute revascularization therapies, while his INR level was over 1.7. He was admitted to stroke unit in order to monitorize him, particularly to monitor his heart rate, then to determine stroke etiology, and of course to start with early secondary stroke prevention therapy. Next day, on a magnetic resonance imaging, we confirmed that our patient was having ischemic stroke. One smaller lesion was found in parietal juxtacortical region, and bigger ischemic lesion was found in temporo-occipital region. Ultrasound and CT angiography examination of the cervical arteries showed both that patient is having significant stenosis of left internal carotid artery and non-significant stenosis of the contralateral internal carotid artery. At that moment, we are facing a treatment decision which depends on stroke etiology. We are asking ourselves if our patient is having cryptogenic stroke in terms of while he's having multiple stroke causes. For sure, he's not having really cryptogenic or not investigated etiology because we performed the thorough diagnostical workup. It is very well known that atrial fibrillation is not always a culprit of stroke in patients with atrial fibrillation plus stroke, because it is very well known that 10% of all ischemic stroke result from embolism secondary to atrial fibrillation, that nearly 1/3 of patients with atrial fibrillation suffer from non-cardioembolic stroke, and that up to 24% of patients with stroke having atrial fibrillation demonstrate at the same time high-grade cervicocephalic artery stenosis over 50%. When we compared features that are speaking in favor of cardioembolic stroke and the clinical and other features that are speaking in favor of atrial thrombotic stroke, we could see that all of them were speaking in favor of that our patient is suffering atrial thrombotic stroke. It's male sex, then he's a smoker, he's having dyslipidemia, he was suffering transient ischemic attack in the same vascular territory as high-grade internal carotid artery stenosis on the left side. He's having paroxysmal atrial fibrillation, but he was adequately anticoagulated at the stroke onset. He's having significant artery stenosis, which is internal left carotid artery. He's having cortical, subcortical borders on infarcts within the same arterial system without hemorrhagic transformation at the magnetic resonance imaging. That's why we are continuous with our search to prove that the patient is not having sources of cardioembolism and that he's maybe having sources of arterial embolism. That's why we perform thoracic and transesophageal echocardiography and also ultrasound transcranial Doppler detection of the microembolic signal. And we found that our patient is not having any sources of cardiac embolism, including having normal left atrial size. But on the other side, with the microemboli detection on transcranial Doppler, during 60 minutes monitoring, we found that he's having 10 microembolic or high-intensity transient signals, which were detected only in the left middle cerebral artery. Based on the literature, knowing that our patient is having only unilateral appearance, which is ipsilateral to the stenosized internal carotid artery, we are facing probably with sources of microembolic signals which are coming from the carotid stenosis but not from the cardiac source. At that moment, we are thinking about that our patient who is suffering from non-valvular atrial fibrillation is having not cardioembolic but large vessel or atherothrombotic stroke because he had left retinal TIA, he had left border zone stroke and second one in the same internal carotid artery territory. He had left internal carotid artery significant stenosis. He was adequately anticoagulated with normal left atrial size, and we detected microembolic signals only in the left middle cerebral artery. Based on this data and based on the current recommendations, we have transferred patients to the vascular surgery where carotid endarterectomy of the left internal carotid artery was performed because it is highly suggested that patients who are having TA or non-disabling stroke and significant internal carotid artery stenosis should be having carotid endarterectomy performed within 2 weeks after the symptoms onset. That was done in our patient. Carotid endarterectomy of the left internal carotid artery was performed within 2 weeks after the symptoms onset. At that moment, we are facing also other recommendations that the patients who are having carotid endarterectomy afterwards should be for at least 3 months on antiplatelet therapy, particularly aspirin is highly recommended with the highest level of recommendation. That's why we're asking ourselves what to do with the patient who is having non-valvular atrial fibrillation plus stroke, which is probably a large atherosclerotic stroke due to large vessel disease. And the dilemma is not only ours because there are no data in the literature and there are no clear recommendations and guidelines about benefit of dual antithrombotic treatment in these cases. We have to prevent those patients from cardioembolic stroke with anticoagulational therapy and from recurrent ischemic events due to a large vessel disease with antiplatelets. Novel oral anticoagulants have been shown to be protective against cardioembolic stroke in patients with atrial fibrillation, but there are limited data that are showing that there is efficacy in preventing of non-cardioembolic stroke with novel oral anticoagulants. On one side and on another side, oral anticoagulants in patients with cerebral small vessel disease are associated with increased risk of intracerebral hemorrhage and cerebral microbleeds. That's why, because we are lacking clear recommendations for these clinical situations, there is a need for individual approach and assessment. It is probably reasonable that combination of aspirin and oral anticoagulants with strict control of risk factors and intervention therapies for carotid artery disease may be considered. That's what we done in our patient. And after assessment of other comorbidities, peripheral or coronary artery disease, a risk of GIT bleeding and assessment of Hasbled score on one side, and assessment of concomitant presence of cerebral small vessel disease and amount of cerebral microbeats as a risk for intracerebral hemorrhage, we are giving decision which therapeutical strategies and which combination of anticoagulation and antiplatelet should be applied in our patient. It is Probably clear that carotid endarterectomy plus aspirin is not enough to prevent recurrent stroke, because he is also having increased risk not only from atherothrombotic stroke but also from cardioembolic stroke. His CHATVAS score is 4 on one side, on another side his Hasbled score is 3, and on magnetic resonance imaging susceptibility weighted imaging there are no microbleeds, so there is no increased risk based on this criterion that the patient would suffer from intracerebral hemorrhage while on anticoagulational therapy. Deciding which anticoagulation therapy should we apply in patients who had to be on anticoagulation plus antiplatelet therapy for at least 3 months after carotid endarterectomy, we are facing the literature which is again lacking, but clearly showing that probably apixaban is having the most favorable effectiveness, safety, and persistence profile in comparison with warfarin and with other novel direct oral anticoagulants when it is combining with antiplatelets, particularly aspirin. To make the situation more complicated, our patient is not facing only risk for cardioembolic stroke, risk for recurrent large arterial-atherosclerotic stroke or atherothrombotic stroke. He's having peripheral arterial ischemic disease. While during he was hospitalized on vascular surgery, it was found that he's having significant aortoiliac steno-occlusive disease, Larish syndrome, which needs to be treated with antiplatelet, but not only with anticoagulation therapy. That was another one of other reasons why we had to decide to treat patient in combination of anticoagulation and antiplatelet therapy. So if you want to summarize, in this case of 75 years old man, in acute stage we discontinued warfarin and started antiplatelet, aspirin 300 milligrams, plus high doses of statin until carotid endarterectomy was performed within 2 weeks after the onset of large arterial-atherosclerotic stroke, knowing that he is at high risk of recurrent stroke because he is having positive microembolic signals. After carotid endarterectomy was performed within 2 weeks, which was highly recommended, and after we continued with aspirin 100 milligrams for at least 3 months, which is the highest level of recommendation, we introduced novel oral anticoagulant apixaban while we wanted to protect him from having cardioembolic stroke. I will remind you that the patient is having paroxysmal atrial fibrillation for at least 1 year. A long-term dual antithrombotic therapy after assessment of potential risk and benefit was balanced. I showed you that he's having increased risk not only from cardioembolic but from a large arterial-atherosclerotic stroke. He's having peripheral artery disease and not so increased risk for intracerebral hemorrhage. That was the reason that we decided to put the patient on prolongated dual antithrombotics, means anticoagulation with apixaban and antiplatelet with aspirin 100 milligrams a day. While I am sending you warm regards from Belgrade in Serbia, I would like to thank you very much for your attention, and I'm awaiting your questions and suggestions for the discussion. Thank you very much.